Welcome to the deep dive. Today, we're really plunging into oncology. It's a complex field, isn't it? Always changing, but so human.
Absolutely.
And if you're maybe a first-year medical student listening in, we're designing this as your, let's say, shortcut to getting well-informed on cancer prognosis and treatment.
Mm,
We really want to make this stuff stick, help you build that, mental map, a diagnostic toolkit, if you will, for navigating a patient's cancer journey.
that's the goal.
Our sources today are mainly from a great lecture by Dr. Prem Roy, plus some other useful bits, all focused on malignant tumors.
Right.
And we have to start with the big picture because this matters a lot. Did you know every 2 minutes, someone in England gets told they have cancer?
It's a staggering statistic, truly.
It is, but there's good news too. Cancer survival, it's actually at its highest ever. More than half of people are living 10 years or more after diagnosis.
Which is fantastic progress.
It's not just numbers, it's real people, real hope.
And that positive trend is exactly why understanding the details of oncology is so vital for clinicians like you joining the field. Because while the overall picture is better,
Yeah.
predicting for an individual patient, figuring out the best plan, well, it's far from exact.
Yeah.
But it is estimable. We could definitely build a strong, informed picture.
Okay.
So today, we'll cover the basics, how we assess a tumor, the main treatment types, how we monitor things.
Good plan.
And to kick things off, maybe picture this. You're seeing your very first patient, you suspect a malignant tumor.
Mm-hmm.
What's the absolute first, most crucial piece of information you need? Start understanding their prognosis to guide what you do next.
Oh,
Keep that question in the back of your mind. We'll circle back to it.
good one. Because, every patient is unique. When someone comes in with symptoms, you're not just seeing a disease, are you? You're building their story.
Yeah.
You're using all this clinical skills, you're learning communication, history taking, and for the main complaint, you'll probably use frameworks like SQUITARS or Socrates.
Right, those acronyms help structure the symptom details. Site, quality, intensity, timing.
All that jazz. And in oncology, every detail there can give you clues about the tumor, can't it?
It really can. And beyond those symptom specifics, you're gathering all that crucial context. Past medical history, treatment history, family history, social history too.
Right. The bigger picture.
And don't forget, ICs. Their ideas, concerns, expectations, these aren't just boxes to tick. They're vital clues about this specific patient. They influence everything.
Absolutely. And then there's this really critical objective measure, the patient's performance status. You hear about the ECOG score a lot.
Yes, the Eastern Cooperative Oncology Group Performance Status, ECOG.
It sounds simple, just a number, but it tells you so much, doesn't it, about their functional ability, their resilience. It really shapes treatment decisions. Can you break down that scale for us?
Sure, so ECOG runs from 0 to 5. 0 means fully active, basically no symptoms interfering with life. A1 means maybe some symptoms, but still ambulatory, can do the lead work. A2, they're up and about more than half the day, but can't work.
Getting more limited.
Right. A3 means they're spending more than half the day in bed or a chair. A 4 is completely disabled, bedbound. And 5, sadly, is death.
So even just knowing that number.
Knowing that number gives you a quick, standardized way to grasp their overall capacity. Can they tolerate aggressive chemo? Or do we need a more supportive approach? It's fundamental.
That makes perfect sense. Okay, so we have the patient's story, their functional status.
Yeah.
But the diagnostic cornerstone, 9 times out of 10 in oncology, it comes down to tissue, right?
Tissue is the issue, as they say. It's absolutely key.
And we need to distinguish between a biopsy, that small sample for the initial diagnosis and grading, and a resection specimen. That's the larger piece, usually removed during surgery, maybe with curative intent.
Precisely. And what's fascinating is how much cancer reporting has changed. 20 years back, a breast cancer report might have been fairly basic.
Yeah.
Today, it's a gold mine of detail. Specimen type, margins, lymph nodes, how many are they involved, and then all the receptor stuff. ER, HAR2, PR status.
Estrogen receptor, HAR2 protein, progesterone receptor.
Exactly. And now even things like homologous repair machinery status, basically. How good are the cells at fixing their own DNA?
Wow.
This incredible precision fuels personalized treatment. It's amazing, but also brings challenges in managing all that data.
I bet. So bringing this together, the patient's story, their ECOG score, these detailed tissue insights, you asked about that first crucial piece of information.
Yes. So what is it? It's not just one thing, is it? It's that comprehensive assessment. It includes the tumor's grade, its stage, the margin status from surgery, lymph node involvement, and that hormonal or gene status.
Oh, okay.
Those are the key prognostic indicators. They give us the likely course for that patient. That's our initial blueprint.
That's a great summary. It connects the patient story to the tumor's biology. So to maybe simplify how we categorize tumors, let's use an anchor. Think grading, staging, and the tissue report itself. These are really powerful predictors of survival, our roadmap.
Good framework. Let's start with G for grading. Grading is all about looking under the microscope, isn't it? Assessing the cellular characteristics. How much do the cancer cells look like the normal tissue they came from?
Okay.
So think of it maybe like a polite society.
Yeah.
Well-differentiated cells, G1, they're still quite well behaved. They look pretty similar to the parent tissue. Like you can still see glandular structures in a G1 colon cancer.
Right. Still organized.
Moderately differentiated, G2, things start to look a bit messier. The nuclei are more varied, pleomorphism we call it, signs of losing control.
Okay. Getting ruder.
Exactly. And then poorly differentiated, G3 or anaplastic G4. These cells are really rude and disorganized. Lots of pleomorphism, big dark nuclei, high nucleus to cytoplasm ratio, weird mitotic figures.
Cell division gone wrong.
Totally wrong. They've forgotten their manners completely, look nothing like the original tissue. If you see pictures comparing normal colon tissue to G1, G2, and G3 adenocarcinoma, the difference is stark.
And that rudeness matters for prognosis.
Directly correlates with survival difference. The ruder the cells, the more aggressive the tumor tends to be.
The rudeness scale. I won't forget that. Okay, so that's grading the tumor's personality. What about S for staging? You called it the battlefield map.
Yes, staging tells us how far the tumor has spread, the overall burden of disease in the body. And the standard system, the one used everywhere, is T&M staging.
T&M, let's break that down. T is for tumor.
Right. How big is the primary tumor, or how far has it invaded locally? For breast or kidney cancer, T stage often relates to size in centimeters.
Okay.
For something like colorectal cancer, it's more about depth of invasion through the mucosa, submucosa, muscularis propria, maybe into the serosa or beyond.
Different criteria for different sites.
Exactly. For melanoma, we often use Breslow's thickness, how deep it goes into the skin.
Got it. So T is local tumor extent. Then N is for nodes.
Lymph nodes. Has the cancer spread to the regional lymph nodes? These are often the first place cancer cells travel to via the lymphatic system.
The first line of defense?
Kind of.
Yeah.
And there's a clever concept here called the sentinel lymph node. That's the first node lymph drains from the tumor.
Ah, the guard posts.
Sort of. The idea is if that sentinel node is clear, the others further down the chain are probably clear too. Surgeons can even biopsy it during surgery and get a rapid frozen section result.
To decide right then and there.
Yes, helps guide how extensive the surgery needs to be.
Clever. Okay, T for tumor, N for nodes, M must be metastasis.
Correct. Has the cancer spread to distant organs? Lungs, liver, brain, bone. Those are common sites. This indicates a more advanced invasion.
Right.
We also talk about transcoolomic spread. That's where cancer cells spread across body cavities, like the peritoneum in the abdomen. Ovarian cancer often does this.
Wow. So how do T, N, and M combine?
They combine to give an overall stage, usually stage 1 through stage 4. Very broadly speaking, stage 1 is early, local. Stage 2 may be more advanced locally. Stage 3 involves regional nodes. And stage 4 means distant metastases.
Okay, 1 to 4. Simple enough principle.
It is. Now, TNM is the main system globally, but you might still see older ones, like Duke staging for colorectal or Ann Arbor for lymphoma, especially in older patient notes or literature. Worth knowing they exist.
Good to know. So all the staging and grading information, especially from the tissue samples, that feeds into the T part of our GST framework, the tissue report.
Exactly. That detailed pathology report brings it all together, the grade, the stage components, T, N, M, margin status, those molecular markers we mentioned. That's the document that guides the whole management plan.
Perfect. So we figured out the tumor's identity with GST. Now let's talk about fighting back. The treatment. You mentioned 5 main pillars.
That's right. A good way to remember them is the acronym SRCHM.
SRCHM. Okay, what does that stand for?
Surgery, radiotherapy, chemotherapy, hormonal therapy, and molecular treatment.
Got it. Let's start with S for surgery. Often the first line, right? Cutting the tumor out.
Often, yes. The main form of treatment for many solid tumors, removing the primary tumor, sometimes involve lymph nodes, occasionally even secondary tumors, metastases.
And you mentioned terms like neoadjuvant and adjuvant.
Yes, neoadjuvant means treatment before surgery, chemo or radiotherapy to shrink the tumor, make it easier to remove completely.
Okay.
Adjuvant treatment is given after surgery. The goal there is to mop up any microscopic cancer cells left behind, reduce the risk of recurrence.
Makes sense. Before and after. Okay, next pillar. R for radiotherapy. The focused strike. How does that work?
Radiotherapy uses high-energy radiation, usually X-rays, to damage cancer cell DNA. This damage leads to cell death, particularly when cells try to divide. It often targets cells in the G2 phase of the cell cycle.
So it messes with the replication.
Fundamentally, yes. The radiation oncologist carefully plans the treatment field to target the cancer while shielding healthy tissues as much as possible. It's usually given in small daily doses over several weeks. That's called fractionation.
And its uses.
It can be neoadjuvant, adjuvant, the main treatment for some cancers like certain anal squamous cell carcinomas, or used palliatively, say, to control pain from bone metastases or stop bleeding.
Okay. Now, you posed a question earlier. Radiotherapy sounds precise, but how might its basic mechanism damaging DNA, hitting dividing cells, cause side effects, both short and long term?
Right. Think about it. While it's targeted, radiation does affect normal tissues in the treatment field, especially those that divide relatively quickly.
Ah, okay.
So acute side effects often relate to inflammation in the treated area, skin redness and soreness, like sunburn. If the gut is in the field, nausea or diarrhea. Fatigue is common too. Swelling.
And long term.
Those can be more serious and develop months or years later. Things like cardiac damage if the heart was near the radiation field for breast cancer, cognitive issues after brain radiation, fibrosis like scarring in tissues, lymphedema if lymph nodes were treated, reduced fertility, and even, ironically, a small risk of secondary cancers caused by the radiation itself.
So the location really matters for side effects.
Critically, and not all cancers respond equally well. We talk about radiosensitivity. Lymphomas, breast cancer, squamous cell cancers are generally sensitive. Others, like renal cell carcinoma, tend to be quite resistant.
Fascinating. Okay, moving from focused radiation to a body-wide approach. C for chemotherapy, the systemic sweep.
Yes. Chemo uses drugs that damage dividing cells throughout the body. Because cancer cells often divide rapidly, they are particularly susceptible.
But not just cancer cells.
That's the key challenge. It's generally not selective. It hits any rapidly dividing cell, which explains many of its side effects.
We'll come back to that. What are chemo's main uses?
Very broad. It can be curative on its own for some cancers like leukemia or lymphoma. It's used neoadjuvantly and adjuvantly, like we discussed with surgery and radiation. Sometimes it's given with radiation to make the radiation work better. That's concurrent chemoradiation. And it's used palliatively to control symptoms and hopefully extend life in advanced cancer.
And the drugs themselves. Lots of different types, I imagine.
Yes, a huge variety, working in different ways. You have antimetabolites like fluorosil that kind of mimic the building blocks of DNA and mess up replication.
Sneak.
You have alkylating agents and platinum drugs like cyclophosphamide or cisplatin that directly damage DNA by cross-linking the strands.
Tangling it up.
Pretty much. Then there are cytotoxic antibiotics like doxorubicin or bleomycin with various actions. Some interfere with enzymes needed for DNA replication. Some cause breaks in the DNA.
Okay.
And antimicrotubule agents like vincristine that stop cells from dividing by messing with the mitotic spindle, the structure that pulled chromosomes apart.
Wow, lots of ways to attack dividing cells.
And usually, patients get combinations of drugs, chemo regimens often given intravenously over several months, sometimes directly into the spinal fluid intrathecally for CNS cancers.
Okay, so back to that earlier point and the question about radiotherapy side effects. Chemotherapy also targets dividing cells, but systemically. How does that connect to its side effects?
It connects directly. Because chemo circulates everywhere, it hits all the body's rapidly dividing normal tissues. Think about what divides quickly.
Hair follicles, cells lining the gut.
Bone marrow.
Exactly. So you see hair loss, mouth ulcers, nausea, vomiting, diarrhea, and critically, bone marrow suppression, low white cells or neutropenia, increasing infection risk, low red cells, anemia, causing fatigue, low platelets, increasing bleeding risk.
Makes sense now why those are so common.
Fertility can also be affected long term. And like radiation, some chemo drugs carry a small risk of causing secondary cancers later on. It really highlights that balancing act, killing cancer versus harming the patient.
It really does. Are there side effects specific to certain chemo drugs? Yes, definitely. Some are notorious. Anthracyclines like doxorubicin can damage the heart muscle cardiomyopathy. Bleomycin can cause lung fibrosis. Cisplatin is tough on the kidneys. Vincristine can cause peripheral neuropathy nerve damage.
Important to know.
And one really critical acute complication to be aware of, especially with leukemia or lymphoma treatment, is tumor lysis syndrome, or TLS.
TLS. What's that?
It happens when chemo kills a massive number of cancer cells very quickly. All the stuff inside those cells gets released into the bloodstream. Potassium, phosphate, nucleic acids, which break down into uric acid.
Like a sudden flood of waste products.
Exactly. And it can overwhelm the kidneys, leading to acute renal failure, electrolyte imbalances. It can be life-threatening if not anticipated and managed.
Wow, okay. Serious stuff. Let's move to the next pillar, H for hormonal therapy. This sounds maybe gentler.
Generally, yes, compared to chemo. Hormonal therapy or endocrine therapy targets cancers that are driven by hormones. Think estrogen receptor-positive breast cancer or prostate cancer driven by testosterone.
Right. How does it work?
It blocks the hormones effect. For breast cancer, drugs like tamoxifen, a serum-selective estrogen receptor modulator, block estrogen from binding to the cancer cells. Other drugs might lower overall estrogen levels. For prostate cancer, treatments block testosterone production or its action.
So cutting off the fuel supply.
Essentially, yes. Generally less toxic than chemo, but they definitely still have side effects related to hormone blockade, hot flashes, mood changes, bone thinning, etc.
Okay. And the final pillar, M for molecular treatment. This sounds very cutting edge.
It absolutely is. This is the heart of personalized medicine. These therapies target specific molecular alterations, gene mutations, abnormal proteins that are unique to or driving the cancer cells.
So hyper-targeted.
Examples.
Classic examples. In colorectal cancer, we test for mutations in the KRAS gene. If it's mutated, the tumor won't respond to certain drugs called EGFR inhibitors. That's cetuximab. So that test dictates treatment.
Wow.
In breast cancer, about 20% of tumors overexpress a protein called HER2. We have drugs like trastuzumab, brand name Herceptin, that specifically target HER2 positive cells. Herceptin, heard of that one?
Another big one is imatinib, or Gleevec, for chronic myeloid leukemia, CML. It targets the specific abnormal protein, BCR-ABL, that drives CML. It revolutionized treatment.
Incredible breakthroughs.
We also look at things like mismatch repair proteins, MMR, or microsatellite instability, MSI. These are involved in DNA repair. If these pathways are faulty, like in Lynch syndrome,
that increases cancer risk, right?
It does. But counterintuitively, for some cancers like colorectal, having MMR deficiency or MSI high status can actually mean a better prognosis. And importantly, it predicts that certain chemotherapies, like 5-FU-based ones, might not work well, but immunotherapy might.
So it guides treatment again.
Precisely. This is truly personalized therapy using the patient's history, their overall health, and the unique genomic fingerprint of their tumor to pick the best and hopefully least toxic treatment.
Amazing. So as we're giving these powerful treatments, S, R, C, H, or M, how do we track if they're working? You mentioned monitoring the enemy's footprint. Is that where tumor markers come in?
Exactly. Tumor markers are substances, often proteins, released by cancer cells into the blood or other body fluids.
Okay.
While a few can help with initial diagnoses like PSA for prostate cancer, maybe AFP for liver cancer, their main use is really for monitoring, tracking the tumor burden during treatment and during follow-up after treatment.
Like checking if the footprints are fading.
That's a great analogy. If the marker level goes down with treatment, that's a good sign. If it starts rising later, it might signal recurrence before anything shows up on a scan. Examples include HCG for certain germ cell tumors, CEA for bowel cancer, calcitonin for medullary thyroid cancer.
So very useful tools for surveillance.
And valuable.
Okay, so we've covered diagnosis, staging, the main treatments, monitoring. What about care beyond active treatment, the longer journey?
Right, it's a continuum. There's ongoing cancer care, managing the disease, often long-term, maybe with maintenance therapy, regular monitoring, supporting the patient. Even for cancers that might not be curable, but can be managed for years, like some multiple myelomas.
Managing it like a chronic illness.
In many ways, yes. Then there's palliative care. It's important to stress, this isn't just for the very end of life. It's for any life-limiting condition, aiming to improve quality of life by managing symptoms and providing support.
For patient and family.
Absolutely. It's very patient-centered. It can happen at home, in hospice, in hospital. The focus is on a meticulous symptom control, pain, nausea, anxiety, breathlessness, but also spiritual, psychological, social support.
And how does that differ from end-of-life care?
End-of-life care is similar in principles, but specifically focuses on the final phase, hours, days, weeks, maybe months leading up to death. It includes all the palliative care aspects, but also emphasizes advanced care planning discussions about resuscitation, maybe making a will, appointing a power of attorney, preparing for a peaceful end.
Important distinctions. And before we wrap up, we should touch on prevention and early detection cancer screening.
Definitely. Screening involves testing seemingly healthy people to find early signs of cancer or precancerous conditions. We have national programs in the UK for cervical, breast, and bowel cancer.
And they work.
Generally, yes, they save lives by catching cancers earlier when they're more treatable. Though there are complexities in evaluating screening. You sometimes hear about lead time bias.
Lead time bias.
It means screening might diagnose a cancer earlier, so it looks like the person survives longer from diagnosis. But it doesn't necessarily change the actual date of death they would have had without screening. It makes evaluating the true benefit a bit tricky sometimes.
Ah, okay. A statistical nuance.
An important one.
And one final point from the source material. A brief mention of autopsy. Maybe not something we think about often in the context of ongoing care.
True, but the post-mortem exam remains a really powerful learning tool. Legally, a coroner might order one. Medically, with consent, it helps confirm the cause of death, understand the full extent of the disease, see how treatments affected things.
A final check, in a way.
And a valuable source of knowledge. Even modern imaging, like post-mortem CT or MRI, is sometimes used now.
Interesting. Okay, so to bring this all home for, say, our first-year med student listener, the patient journey blueprint.
Right. Patient comes in with symptoms.
You take that detailed history, use your Squidars or Socrates, get the PMH, FH, SH, the ICE,
Thorough examination.
targeted investigations, bloods, imaging, biopsies.
And the assessment. What's the site? The diagnosis, critically the staging grade, other key features.
And finally, you pull it all together, discuss with the patient, discuss with the multidisciplinary team, and formulate that personalized management plan.
That's the core pathway.
Fantastic. Well, that's been a real deep dive into decoding cancer's prognosis and treatment. We've covered the GST framework, grading, staging, tissue analysis for understanding the tumor, the SRCHM arsenal for treatment surgery, radiotherapy, chemotherapy, hormonal, and molecular therapies.
Right.
And stressed how vital that individual patient context is, their ECOG status, their full history. Hopefully that mental map is starting to take shape for our listeners.
Hopefully. And maybe one final thought to leave you with. We've talked about incredible progress. Survival rates are up for many cancers. Yet for some, like pancreatic cancer, survival remains stubbornly low globally, often under 15% at 5 years, even as others like lung and liver have seen improvements.
That's a stark contrast.
It is. So thinking about everything we've discussed, grading, staging, our current treatments, what factors or perhaps new research directions do you think hold the most promise for really shifting the needle for these tougher cancers? Something to ponder.
A challenging question, but a vital one. Keep learning, keep questioning, folks. Thanks for joining us on The Deep Dive.